Thank you, merci et bravo.
Well, thank you, and well done to the brave ones amongst you who are still here.
Donc je vais effectivement vous parler.
I am indeed going to try and give you an overview of digestive toxicities that can be encountered in the case of targeted therapies. So, we know most of these digestive toxicities, so I'll give you an overview of the most common toxicities. If we look at the whole spectrum, it's something that we do encounter on a daily basis. The problem is that sometimes it causes a limitation of dose, and it can actually have an impact on quality of life. I will tell you about hepatic toxicity, pancreatic, and also digestive tract toxicity. So hepatic toxicity, I've listed here the different drugs that, all the targeted therapies that cause a certain degree of toxicity. So with almost all of those targeted therapies, you can actually have toxicity. The problem with these drugs is that when they are under phase 1, 2, and 3 study, they are usually tested on patients that have normal hepatic workup, and it's then disseminated in the general population, so you can find that you have hepatic problems that are only detected secondarily, and there's a direct toxicity on hepatic and there can be interactions that can lead to serious problems, immunoallergic also mechanisms, and an impairment of the hepatic function that can be underlying. So direct toxicity on the hepatic parenchyma. And usually when you stop treatment, it ceases fairly quickly. Pancreatic toxicity, you need to be aware that there are sometimes elevation of pancreatic enzymes. So when you have assays of lipase or amylase, it's rarely a full-fledged pancreatitis, and usually it gets better when you stop the treatment. So what are the main categories of drugs that can cause pancreatic toxicity? Usually they're multi-kinase inhibitors, and also EGFR and VEGFR inhibitors. Mechanisms are immunoallergic. Sometimes there are cases of pancreatic ischemia, and it can be linked to a hypertriglyceridemia in case of acute pancreatitis. So there's not much you can do, except if it's a grade 3 or 4, you monitor on a regular basis your lipase and amylase assays. And usually there's a spontaneous resolution when you stop the treatment, and if there's no resolution at grade 3 or 4, then you can induce normalization with specific actions. And here, in the case of renal cancer, 3 months on pazopanib, and the other that had a GIST on nilotinib. Well, you see that to the right-hand side, you have kind of an edema that appears at the level of the pancreas. Another type of imaging that comes from Cochin Hospital in France. And they had a patient that had important modification of pancreatic enzymes, and when they actually dug a bit deeper, they saw that there was a pancreatic atrophy in a patient that had been on sorafenib treatment. So a few reflexes that you should have, but in practice, low incidence. Perforations. Well, ever since the first VEGF inhibitor was introduced, we've had those perforations. So it's rarely serious. It's rare, but it can be serious. In terms of incidence, about 0.9% with a relative risk of 2.14. So what's interesting is to look at in the literature if with VEGFR inhibitors, do we in the case of targeted therapies, do we see a lot of perforations? Well, they actually looked at 109 trials, and 99 were excluded because the toxicity was not reported. So we don't know if these patients had perforations. It wasn't reported. So they found only 16 phase 2 trials and 4 phase 3 trials where there were perforations with a total incidence of 1.3%. So it's not negligible. Is it linked to the disease? It could be. So it's not necessarily higher than the general population with cancer, but it's not negligible. You have to bear it in mind. And with renal failure, usually there have fewer perforations compared with other tumors. And if you look at all those molecules, with sorafenib and axitinib, it's slightly higher. It's very low, so it could still be linked to the pathology, but you should not exclude the possibility that it might be linked to these molecules. And also bear in mind that part of it has not been reported. Bevacizumab, 12,294 patients, 17 phase 3 studies, and if you need to look at the underlying pathologies, there's fairly high mortality. With in the case of perforations, you have 21% mortality, and odds ratio that is doubled. With aflibercept, which targets VEGF, circulating VEGF. Fairly large cohort with different solid tumors, an incidence of 1.9%, mortality of 10.8%, and an increase of risks with an odds ratio of 3.76. So I think we need to be careful with that molecule. Here, as part of the meta-analysis, to give you an illustration of this, you see that globally there is no dose effect per se. Perforations occur mostly in patients with colorectal cancer and more rarely with breast cancer or lung cancer. More interestingly, I tried to extract what was used as an adjuvant. So these are non-metastatic cases, so it's quite interesting to see what's happened. So in this study, which compares Folfox to bevacizumab, you see that there was one case of perforation, fatal, with a patient on Folfox, and you have 3 perforations in patients on Beva, even though their primitive tumor had been resected. So the perforation does not always occur in the tumoral tissue. So here, another study, still bevacizumab. So you see that there are cases of perforations and that you should be on the lookout. So these perforations, what are the conditions that are usually associated with those perforations? Well, chemotherapy, patients that are on steroids, especially in the long haul, when you have an underlying cancer, in particular with digestive tumors, but it's not always the case. Perforations do not necessarily occur where the initial tumor is. When there's an ulcer or when there are diverticulosis, and also obstructions. You have to also be careful when there's an abdominal radiotherapy. Recent endoscopy is not backed up by that much data, and in ovarian cancer, with some molecules, they've stopped using them for ovarian cancer because there were perforations, and when they put some patients back on the molecule after perforations, it was usually because you have to look at the CT scan of those patients, because you have to be careful if there is been a recent abdominal surgery, if there was a number of prior chemotherapies, or if there was an invasion of the digestive tract. And you have to warn patients, because even though it's rare, an abdominal pain should actually ring the bell with patients, and they should come and see a doctor. Diarrhea, well, we knew in the case of chemotherapy with 5-fluorouracil and irinotecan, we knew that there were a lot of cases of diarrhea, so that people even wondered if irinotecan would still be used, but it actually has become less of a problem, but it's still a problem for patients. It has an impact on quality of life. It can induce complications, dehydration, hydroelectrolytic disorders, denutrition, and fatigue. And it also has an incidence on the course of treatment, because patients on targeted therapies need to take their treatment on a daily basis. If we look at the different categories of EGFR inhibitors, if we also look at monoclonal antibodies, they all cause diarrhea, and mostly with the EGFR inhibitors, higher incidence with the EGFR inhibitors compared to monoclonal antibodies, around 5%, but it can actually reach 20% with a toxicity of grade 3, 4, so that patients need to be hospitalized. For HER2 inhibitors, we know that there's a 50% incidence for pertuzumab or for lapatinib, and with 6% of grade 3-4. 6% of grade 3-4 for pertuzumab. With some HER2 inhibitors, you see that it's not negligible. So when you combine two drugs that can cause diarrhea, that can both cause diarrhea, which is the case in that study, you see that the incidence is around 80%, and for grade 3 or 4, we have 20% incidence rate for diarrhea. If we compare with the control group, there is still 1.6% of grade 3. So, this goes to show that those new molecules are not devoid of digestive toxicity, so you need to be aware of it. And just in passing, I draw your attention to the fact that you have a column with all grades and then a column for grade 3 and 4, so that we have no information whatsoever on grade 1, 2. Another illustration here, what I find particularly interesting here, and I'll pick up on that, is the way we assess toxicity. It's kind of a pet project, but I'll I'll come back to it because you have cycle by cycle, week per week, what happens in terms of toxicity, and it gives you really almost an area under the curve in terms of toxicity. So you see the different elements, number of stools per day, etc. And if we remember the previous table with grade 3-4, well, you see that patients under capecitabine and lipitinib usually have problems. And even though you had only 23% in terms of toxicity, well, there's still 30% of patients past the third week that still have diarrhea. Physiopathology, just very quickly, it's not well known at all, not only for EGFR inhibitors, for all molecules. There are probably mechanisms that are linked. There are probably phenomena that have to do with the immune system. There's probably a direct toxicity on cells that are renewed in the villus. There's probably a direct impact on the cells that are at the bottom of the crypt that protect the digestive barrier, and probably toxicity at that level. There's probably toxicity, that's a hypothesis, a variation of the microbiota. It's very much in fashion at the moment, and we don't know what kind of impact it can have on the digestive population, and in particular in terms of absorption and pharmacokinetics of our drugs, because that has an impact on that. So there's a big question mark on the mechanism in terms of pharmacokinetics. TKI, well, yet again, toxicity, I'm going to gloss over that because I know those tables are a bit dry, but suffice it to say that there's still a problem to be addressed here. If we look at all the trials for VEGF TKI inhibitors, if we look at the incidence of diarrhea, if we look at some molecules between 35, 50, 54% of incidence, so it's fairly high. So I'll skip that. What's interesting here as well is the way it's reported, the way those digestive toxicities are reported. You remember this trial, which is fairly big-scaled, pazopanib versus sunitinib. If you look at the Princeps article in the New England Journal, there's no diarrhea incidence. Why? Because in the primary table listing all toxicities, it only includes toxicities that are different between the two molecules. So you have to look at the appendices that are online, and you find this table with all grades of toxicity, 63% and 9% of grade 3. So fairly similar if we compare both molecules, but nothing in that paper on grade 1 or 2. If we want to find out more about grade 1, 2, well, there's something interesting here. That's the study published by SQDA and others, and looking at pazopanib versus sunitinib. Well, you have actually on sunitinib you have almost no grade 3 or 4 diarrhea. So it may have to do with the different type of reporting, but you can find the figures for grade 1 and 2 so that we can have a better assessment of direct toxicity. Let's look at a bit of at some imaging. Well, there's a team that looked at CT scans of patients on sunitinib, more than 100 patients, and you can see here clearly that 62% developed an edema. You see here a thickening of the membrane, mucous membrane, and here, in part of the ileum, you see edemas at that in that section here as well. So 62% had an edema whilst on treatment, 67% had a grade 1 or 2 diarrhea, 10% had a grade 3 diarrhea, 89% had edema-related issues, and had diarrhea. VEGF inhibitors, we mentioned perforations, but if we look at bevacizumab on its own, there are cases of diarrhea. With the aflibercept, well, it's harder to tell. And the latest molecules, with the BRAF inhibitors, I won't come back to that, but fairly high incidence of diarrhea. Ipilimumab was detailed before. Incidence for all grade diarrhea, 42%. High grade incidence, 8.4%, which shows as diarrhea, abdominal pain, blood or mucus in stools, and sometimes febrile, and sometimes colitis, which can be serious in 5% of the cases. So how do we assess this? Well, we actually fail to assess it efficiently. Well, less than 4 stools, 4 to 6 stools, over 7 stools, and that it remains fairly general and probably does not reflect the incidence. And there are probably other methods to quantify diarrhea, in particular that could be done by the patient themselves. So here interesting data about patient versus clinician symptom reporting. So actually there's a questionnaire for the patient and a questionnaire for the clinician, and you see that there are 85% convergence, but there is 11% and 13% discordance between patient and clinician on the assessment of diarrhea. In terms of what we can, the tools we can use, well, questionnaires, of course, also clinical exam, so as not to let a serious symptom go unheeded. Guidelines, where they're few and far between, basic medicine, but nothing really specific. What we try to do is, with a dedicated nurse and a gradual delegation of tasks, we train that nurse in asking the right questions to patients so that we can figure out when we have to stop the treatment and when she should refer it to the prescribing doctor. So in conclusion, that toxicity is often underestimated and not well assessed. It can have an impact on quality of life. These mechanisms are not well known, and we should really be very watchful. Diarrhea is usually the most problematic for patients. And there might be an impact on efficacy, and that brings us back to pharmacokinetics. We have to be very, very watchful. We have to convince patients that they should call us if there's anything to report. Information prevention, there has to be a collection of data by patients. We have to educate patients, and we have to adapt dose and pharmacology. And I think that was the last presentation.